Good afternoon, everyone. This is Joy Cameron with the Visiting Nurses Association of America. I appreciate you tuning in for today's webinar on the home health conditions of. As you know, these regulations were just released, and we are recording this webinar so that some of your colleagues and compatriots will be able to sign in at a later date and catch in on the information that we've been sharing. We are going to mute your lines until we get to the questions and answer portion. There's also the ability to ask questions through the chat function on the side for those of you who signed in through the website. Then also, just to let you know, on our website ourselves, we are going to be listing this recorded webinar as well as PowerPoint, among other resources that we'll review at the end of the webinar. I'm delighted to say that Robert Wardwell has joined us again for today's webinar to help go through the conditions of participation, and we appreciate his time and his efforts on this issue. So with that, I'm going to go ahead and get started. Just quickly, as an overview of everything that we're going to discuss today, we are going to just do a quick background on the COPs, or conditions of participation, discuss with you all the timing, review this section review of all the different changes, and then this is a very important part. We're going to request your feedback on implementation. What are some of your concerns, et cetera, that you have, as well as just your questions and answers, and then a review of the resources that will be available on the VNAA website. So with that, just a brief background on the conditions of participation. This is where I'm going to ask Bob to join me. You know, we have been waiting quite some time for the new release. About 2 years ago, we sent our comment letter in on the proposed rule, and it's been almost 20 years since we have seen an update of the full set of rules. Bob, did you have some thoughts you wanted to share on this?
Well, I guess one thought is you have to have lived a relatively long time to have gone through the COP process as a career. These actually, you know, first appeared back in 1997 when I had just been asked to come back to the Medicare side of the house at CMS to do something called the Home Health Prospective Payment System. And so that kind of dates how long they've been sitting around. Since that time, there have been several iterations. Only a few of them actually became public. But CMS, believe it or not, has been working on this with a relative degree of activity off and on for those 20 years. The principal reason these things took this long to get out, other than the complexity and the importance of them, is that they didn't involve money. And money is what gets something published in the Federal Register. Believe it or not, you can't publish, you know, whatever you want, whenever you want. There's a priority list to get things through the whole process of clearance. So when Joy told me that back in the fall that she thought these things might actually be published, I'd kind of been there before many times, so I was a bit skeptical. But it was with some great surprise that they finally got published, and I guess the change of administration finally had enough political oomph to get them out the door. You may recall that after the '97 attempt, there was actually a publication of OASIS final rules in 1999, and then some OASIS data collection and transfer things back in 2005, and then of course the 2014 version of these rules, and the comments that VNAA submitted on your behalf, and now the final rule. And I've looked through I think all of the VNAA comments now, and they have been responsive to most of them. Not always as fully as we might like, and one of those has to do with implementation. So I guess with that as kind of a background, these are important rules, not only because they decide who gets certified and who gets decertified, you know, in Medicare themselves, but they also form the basis of all the accreditation standards for JCHO, for CHAP. So all those things are going to have to be changed based on these COPs. I think that's probably enough on that.
Great. Thank you so much for that, Bob. You know, one of the most important tools that Bob and I have talked about for, you know, implementing this process, and that's why I've moved on to the timing slide, is one of the things that will be extremely valuable will be the interpretive guidelines from CMS, which still have not been published, and that will be one of the things that we are pushing pretty hard on them so that we can see the exact scope of the timing. So the regs or the conditions of participation were officially released in the final rule version on January 13th, 2017. They have an implementation date of just July 13th, 2017. As Bob mentions, and of note is us, and I would say the rest of the home health world, asked for a much longer implementation date, much more closely to at least a year to 18 months, depending on what organization it was. But they've gone with the truncated timeline of just 6 months, except, and that's an important underscore, for performance improvement projects reflecting scope, complexity, and past performance of the home health and document projects. So just as a note, those projects have an implementation date of January 13th, 2018. I think much of that also has to do with the ability to see where your data collection is and the timeliness of that. So as we know, in many cases, data is not immediately available, and so that would be a good reason why there's a longer implementation date there. But for the rest of it, there is, in fact, a July 13th implementation date. So obviously, VNAA will continue to work very closely with you so that we can get everyone there as quickly and as efficiently as possible. So that being,
I might add something that just came in. I got an email from one of my old friends who's one of the people that are responsible for this reg over at CMS, and she's indicated to me that the interpretive guidelines are being developed right now, but it will take a significant amount of time, and clearance will add time to that, so we do not expect any interpretive guidance soon, and they're not going to speculate about when the release date is, but they do indicate that they will be sharing a draft of the interpretive guidelines with the provider groups, including VNAA, prior to finalization, so they're not on the edge of the seat, that's for sure, which makes 6 months even a little more strange to have to deal with.
yes, well, we'll see if we can shove them to the edge of that seat, so they'll feel a little more fire. Thank you for that. Okay, so we're going to start the section overview at this time. So just going in chronological order in the way that the guidelines are set up, these are the areas where they have modified or updated definitions. These are all the different definitions that they changed. This is really one of those areas where you just want to read the actual regulations themselves rather than having us truncate them or summarize them for you quickly. You know, it's really going to be a multi-part process of making sure that you're fully in line, and that's going to include resources that we offer you, as well as the reg itself, as well as, I would personally say, the version of the reg that includes the comments, especially until we get these interpretive guidelines. The next section that had a change, this is section 484.45, which is the release of patient identifiable OASIS information. I'm sorry, it's 484.40. This is really, this section just really works on ensuring the confidentiality of all patient data. That is not something that is new to many of you who have been dealing with OASIS data and HIPAA compliance. So this is just a reiteration of that rule. Reporting OASIS information, there are several areas of this. The first area is the encoding and transmitting of OASIS data. This requires that you both encode and transmit within 30 days of completing that assessment. The section on accuracy of encoded OASIS data just reiterates the importance of accurately reflecting a patient's condition at the time of assessment. The next section was transmittal of OASIS data, and that talks about being able to successfully transmit test data to the QIES system or the CMS OASIS contractor in proper format. The transmission must be compliant with the Federal Information Processing Standard and also include a branch identification number as applicable. So there are multi-parts to transmission. And then data format is just encoding and transmitting data using the CMS required record layout, ed specs, and the data dictionary. Okay. Okay. For patients' rights, which is the next section, there are several sections under the Notice of Rights. We must provide to the patient and representative during the initial evaluation visit before providing care, and this is just their Notice of Rights. Included in these rights, it will be the transfer and discharge policy and be understandable to a patient with limited English and accessible to those with disabilities. It also includes information about contact information for the home health administrator, the OASIS privacy notice, obtaining patient or legal representative signature for confirmation of these rights. And I would say for the beginning portion of this section, for those of you who joined in for the non-discrimination webinar, this is very much in line with those regs that you guys have already heard about. Additionally, you'll need to provide verbal notice in primary or preferred language using a free interpreter if needed no later than the completion of the second visit. In that non-discrimination webinar and tools, we have information that CMS has provided more specifically about that, and provide a written notice of rights, transfer, and discharge policy to patient select representative within 4 business days of initial evaluation. Under the exercising of rights, if the patient is legally lacking capacity, it's important to have the rights exercised by the legally appointed person. And if they are not legally lacking capacity, the rights may be exercised by a patient's representative as well. And if lacking legal capacity, the patient may exercise those rights as allowed by a court order. The rights of the patients themselves, these are very consistent with what most of you are already doing: respect for property, free of abuse, making complaints, be able to participate, be informed, consent, refuse, etc. And there is a large list of things that they have the right to that include assessments, care, plan of care, patient-identified goals, etc. So all of this is laid out in both our summary as well as the reg itself, and seems to be very much in line with the work that most of you are doing already. The next section on patients' rights refer to transfer and discharge. They have the right to be informed of a transfer and discharge policies, and only in transfer or discharge when necessary for the welfare or agreed to by the responsible physician. As you all know already, agencies must arrange safe and appropriate transfer, and also when a patient and payer will no longer pay, the home health agency and the responsible physician agree goals achieved or no longer need home health care, patient refuses services. Obviously, these are all the different reasons that folks are able to discharge. Those include patient or others in home as disruptive, abusive, uncooperative, so their operations are seriously impaired. But that can only occur after advising the patient representative, aftercare physician, have made efforts to resolve the problem and have provided contact information for other sources of care. And you very much need to document that process. And then also, obviously, transfer discharge actually occurs when a person passes. Or the next section is the investigation of complaints. There are a list of reasons for must investigate complaints. That includes treatment, mistreatment, abuse, misappropriation, and injuries. There is the documents will be investigated and there will be a resolution. You must show a plan to take action to prevent further problems, including reprisals during the investigation, as well as staff must immediately report violations to home health and authorities according with state law. So that will vary depending on the state that you live in. And finally, this section includes accessibility, which talks about the availability of providing plain and timely information, again, in that manner that is most accessible to the patient. Again, this goes back to some reliance on the ADA, the Non-Discrimination Act, and other areas that we look at when it comes to limited English proficiency, and also the level of documentation. It's important to remember the healthcare literacy levels when providing this information. So our next section is comprehensive assessment of patients, and I know this is an area that many folks have been interested in based on your emails to me. The first section is the initial assessment visit. The RN's initial assessment visit for Medicare eligibility for home health benefit, including homebound status, still continues to be within 48 hours of referral or return home or the physician ordered start date. For rehabilitation services only, the initial assessment may be made by a rehab professional. The completion of the comprehensive assessment must be completed no later than 5 calendar days. So it's important to keep in mind some of the new timings that are included in these assessments. Content of the comprehensive assessment, this includes current health, psychosocial, functional, cognitive status, patient strengths, goals, and care preferences, including measures of progress and measurable outcomes. Highlighting the patient's continuing need for home care, patient's medical, nursing, rehabilitation, social, and discharge planning needs. A review of all modifications that med reconciliation that we speak of so oftenly to identify potential adverse effects, drug reactions, ineffective drug therapy, significant side effects and drug interactions, as well as duplicative therapy and non-compliance issues. The need to identify primary caregivers and others supports, including willingness and or their availability and schedules of the patient's representative, and incorporate that into the current OASIS. And then finally, the update of the comprehensive assessment. This must be updated as frequently as the patient condition warrants due to a major decline or improvement, but no less than 5 days after every 60-day episode, unless the beneficiary elected transfer, there was that significant change in condition, there's a discharge or a return in the same 60-day episode. Also, it's important to note that within 48 hours of a patient's return from a hospital admission of 24 hours or more, except for diagnostic testing or a physician-ordered resumptive date, the comprehensive assessment must be updated at that time and again at discharge. Moving on now to care planning, coordination of services, and the quality of care. The plan of care, the individual plan of care, must have all the pertinent diagnoses, and you'll see in our summary we discuss all the mental, psychosocial, cognitive services, etc. Safety measures, nutritional, medications, patient risk, interventions need to take, patient and caregiver education for timely discharge, interventions, some outcomes and goals identified by the patient and the home health agency, information on advanced directives, additional items that the home health agency or physician may choose to include. All of the patient's care orders, as well as any verbal orders, are then going to need to be inputted into the care plan, our plan of care. The next portion covered is the conformance to physician's orders. It's important to make sure that drug services and treatments administered only as ordered by the physician, including that also influenza and pneumococcal vaccines per agency policy developed in consultation with physician, and after no contraindications, verbal orders are accepted only by authorized personnel. Verbal orders must be documented in the clinical record, signed, dated, and timed. Verbal orders often must be authenticated and dated by a physician in accordance with your state laws, regulations, and your agency's policies that you've already established. Reviews and revisions of those plans of care. The physician must revise the plan of care as frequently as the patient's care required, which we discussed earlier under the beginning of the plan of care. And then also that has to occur no less than every 60 days. The home health agency must promptly advise physician of changes that suggest objectives will not be met or achieved, and the plan of care must be altered. Those revisions, including those related to plans for discharge, must be communicated to the patient, their representative, caregiver, and all physicians issuing orders. The next portion of this section of the reg is the coordination of care. The home health agency must assure communication with all physicians involved in the plan of care, integrate all physician orders and services, coordinate care delivery, ensure patients and caregivers get appropriate training, including the those necessary for discharge. And finally, the written information to the patient. The home health agency must provide the patient and caregiver written instructions on, and this includes their visit schedule, patient medication schedule, treatments, pertinent instructions, and name or contact information for the clinical manager. I think it's in this section that I've had conversations with a few of you that we've discussed the importance of working with some of our electronic medical record or companies and vendors, so that if there was a way when any new visits are scheduled or medication changes, it codes and allows for a print off, because you do have to provide this in written form. So if this was something that was done in a way that was a little more automatic, instead of reminding yourself every time that you have to then give written notice to a patient every time there's a visit schedule or treatment done, or a list of when these things are, I think that this would be an area where a level of automation would be greatly appreciated by you all. The next section is the quality assessment and performance improvement. Again, just as a reminder, this is that area where the performance improvement projects that are discussed, those are the ones that have the January 1st of 2018 implementation date rather than the July implementation date. Really, the project scope under quality assessment and performance improvement is that they want to be able to show a measurable improvement in outcomes, patient safety, and quality of care. And when it comes to program data, home health agencies must use quality improvement data, including OASIS measures, to monitor effectiveness, safety, quality, identify opportunities for improvement. Frequency and detail of data collection must be approved by the home health governing body as well. Your program activities must focus on high risk, high volume, or problem-prone areas, considering the incidence, prevalence, severity, and lead to immediate corrective action on any problem threatening health and safety of the patient. You must track adverse events, analyze causes, and track performance to ensure sustained improvement. I think that many of you are already undergoing internal performance improvement programs and plans that you've already had in place. This is just a codification of that work that you're doing, and they are going to want to talk about these projects reflecting the scope, the complexity, and past performance of the home health agency, documenting these projects, reason for conducting, and measurable progress. This is where I would mention that I think those states that are already doing the home health value-based purchasing program or have begun that work, I do believe some of the analysis and work that are being done in those states are going to aid you greatly in the work in this area. And then finally, for executive responsibilities, the home health governing body responsible for ensuring that a home health-wide ongoing quality assessment program addressing quality and patient safety, all improvement evaluated for effectiveness, clear expectations are established, implemented, and maintained, and the findings of fraud or waste are appropriately addressed. This section just discusses infection prevention and control. It is pretty cut and dry. Home health agencies must follow accepted standards, precautions, and control infections and communicable diseases. I believe that most of this is already within your body of your work. Maintain a coordinated agency-wide surveillance, identification, control, and investigation integral with QAPI. Have a method identified to identify problems and plan for appropriate actions. Obviously, under the education section, you must provide infection control education for patients, staff, and caregivers. Again, I think this is just an underscore of the work that you already do. Under skilled professional services, the provision of services by skilled professionals. This talks about services authorized, delivered, and supervised by only those qualified under these rules and who practice per home health agency policies and procedures. Responsibilities of skilled professionals include ongoing interdisciplinary assessment of the patient, develop an evaluation of plan of care with the patient, representative, and caregiver, provide services ordered by a physician, plan of care, patient, caregiver, family counseling, patient, caregiver education, preparing clinical notes, communication with all plan of care physicians, participation in a quality assessment and performance improvement, and in-service training. When it talks about the supervision of skilled professional assistants, the nursing must be supervised by an RN, rehab assistant supervised by an OT or a PT, and medical social services assistants must be overseen by a social worker. This section covers the different home health aid services. When they are discussing the qualifications of home health aides, there is the requirement of a successful completion of home health aid or a nursing aid training and competency program or state licensing program. There must be no lapse in paid practice for 24 months without completing a new program. The content and duration of the home health aid classroom and supervised practical training. There are requirements around the number of practical training supervision under an RN for 75 hours, minimum of 16 hours of classroom before 16 supervised hours of practical training, and the list of what these programs must address. Our summary includes this information. Obviously, this would include training for all the basic nursing needs as well as other tasks permitted by state law, and the home health agency is responsible for this training and documentation. I know that many of you who have home health aides under your organizations have relationships with community colleges and other training entities, and it would be important to make sure that they are abiding by these new conditions of participation. Competency and evaluation of this training must complete a competency evaluation by written exam and observation by an RN, and the home health agency must maintain this documentation on site. In-service training, the home health aide is required to do 12 hours of in-service training every 12 months. Eligible training and competency evaluation organizations, agency within compliance and within 2 years that did not permit unqualified home health aides, not subject to extended survey for substandard care, not assessed civil monetary penalty of $5,000 or more, and no compliance deficiencies endangering health and safety, and no government-imported temporary management, not terminated, and no penalty of $5,000 or more for standards not subject to payment suspension, nor have been closed or patients transferred to the state and not excluded from participating in federal health care programs. So in order to do those things, you have to, in order to be an eligible training and competency evaluation organization, you have to have all of those things in compliance. Home health aid assignments and duties, those have to be assigned by an RN or skilled professional with written instructions. The services must be ordered by a physician in the plan of care, be permitted under state law, and consistent with training. These duties include, obviously, hands-on personal care, simple procedures, and extending skilled care, assistance with ambulation, exercises, self-administered drugs. They also must be part of the interdisciplinary team, reporting changes to skilled staff and making appropriate records. The supervision of these home health aides, there must be an on-site skilled visit every 14 days. If an area of concern, the skilled staff must observe an annual on-site to observe each aide. If the patient is not receiving skilled care, it must do an observation every 60 days. If there's a problem in the observation, the home health agency must do a competency evaluation. Supervision must include furnishing care in a safe and effective manner, following plan of care on assigned tasks, maintaining communication with the patient, their representative, caregiver, family members, and demonstrate competency on these assigned tasks. They must comply with infection prevention and control, report changes in the patient condition, and honoring patient rights. If the home health agency provides the home health aid under these arrangements, they must also ensure overall quality of care by the aide, supervise aid services, and ensure aides meet with training and competency requirements. And finally, individuals furnishing Medicaid personal care aid only services under a Medicaid personal care benefit. If aid services under Medicaid personal care, you must meet state requirements and demonstrate competency in the services provided. Obviously, each state is going to have individualized requirements for their Medicaid programs. This section is the compliance with federal, state, and local laws and regulations related to the health safety of patients. The first section talks about disclosure of ownership and management information. In complying with this, you must disclose that certification requests for each survey, change in ownership, etc., all the names and addresses of persons with ownership or controlling interest, officers, directors, agents, managing employee, names, addresses, etc. All of this is listed in our summary. Licensing, the home health agency, their branches, and all persons furnishing services must be licensed, certified, or registered by the state licensing authority. For laboratory services, if the home health agency does do laboratory services, they must be in compliance with the regulations. And then home health agencies referring specimens to a lab, the referral lab must be certified in appropriate specialties as per Part 493, which is another part of the CFR. Emergency preparedness, again, many of these aspects will seem familiar based on the new emergency regulations that came out. And again, we do have a full webinar on those, but just briefly to go over this with you all, the home health agency must maintain an emergency preparedness plan that is reviewed and updated annually. There is a list of requirements of what the plan must include. It talks about different forms of hazards and strategies for events, risk management, thinking about delegations of authority and continuity of operations, and succession planning. They must be processed for full cooperation and collaboration with all levels of government. So again, I would refer you to our emergency preparedness webinar that goes in greater detail. Speaking to the policies and procedures, these plans for patients must be included in each patient assessment, procedures to inform state and local government of home health agency patients in need of evacuation with medical, psychiatric, and environmental information. Again, there will be rules within state and local areas that also modify some of these. It's also important for patients that do home health patients that do not have immediate family caregivers or a place to go. It's important that the state and local areas know about this. There's going to need to be a system of medical documentation that would also preserve confidentiality and yet at the same time allow for access in case of emergency. So that's a bit of a challenge. Additionally, your communication plan that you develop must comply with federal, state, and local requirements that are updated annually. Testing and training. The home health agency must have an initial preparedness training for all staff, volunteers, and arrangement providers. There is, you have to be a part of these exercises that will happen annually and participate in a full-scale community-based exercise. The emergency preparedness regulations have stated that these full-scale exercises that you would participate in on a community basis are actually called table exercises. So we're not actually going to have people evacuating buildings with patients, etc., but rather a table exercise to talk about within the community of what would need to be done as written in the emergency preparedness reg, unless your area wanted to do something more elaborate than that. But again, it's something that you would want to coordinate with your local and state agencies to discuss. And then also there's a section in about integrated healthcare systems and the work that they must do under emergency preparedness. They can elect to participate in a systems drill if each part of the system actively participated, was developed to take into account each part's unique circumstances, patient services, and demonstrates each part actively uses and complies with the integration program. The plan complies with a documented community-based all-hazard risk assessment, a separate risk assessment for each certified part of the integrated system, and coordinated communication plan, testing, and training. So that will be important for our folks with integrated healthcare systems, that they must have a plan as if they were individual as well as within their system. Going on to the next section of the organization and administration of services. They did do a little bit of updating and modifying in this area. The governing body must assume full legal authority and responsibility for the home health agency's management, operation, services, financial operations, budget, operational plans, quality assessment, and performance improvement. The administrator must be appointed by and report to a governing body responsible for all day-to-day operations, assure that the clinical manager is available all operating hours, and ensure employees qualified personnel, develop personnel qualifications and policies, designates a qualified and pre-designated person authorized in writing by the administrator and governing body to assume all responsibilities and obligations when the administrator is not available, and the administrator or their designee is available all working hours. Additionally, there's been some updates throughout the clinical manager, the parent-branch relationship, services under arrangement, services furnished, outpatient physical therapy or speech-language pathology services, and institutional planning. That is all included in our summary. Also, for clinical records, contents of the clinical record must contain current comprehensive assessment, clinical notes, plan of care, physician orders, all interventions and responses, including medications, plan of care, goals and process, contact information for the patient representative, primary caregiver, primary physician for all post-home health discharge, completed discharge summary, and completed transfer summary. Under authentication, all entries must be clear, legible, complete, and authenticated. Signature and title or secure unique computer entry must be dated and timed. Retention of records. Records must be retained for 5 years after discharge or longer if your state law differs. Policies must provide for retention if it is discontinued, even if it's discontinued operation, and home health must inform state agency where those clinical records may be maintained. Protection of records must be protected against loss or unauthorized use and comply with rules on protected health information. That's just a HIPAA requirement. And then finally, the retrieval of clinical records must be made available to a patient on request free of charge at the next home health visit or within 4 business days if earlier. So under personnel qualifications, these are all the different qualifications that have been updated. In some of the cases, we would refer you directly to the regulation itself because the language can be a bit complex and specific. In some cases, it's going to refer you to other areas of the, for Medicare for physicians, et cetera. Many of them refer back to the requirements that for these audiologists, administrators, et cetera, to what their licensing agencies require. But again, that is a larger summary document. I think if I was to go through all of these, you guys might have it out on me. So at this point, I really want to get from you, I know this has been a lot of information all at once, but if you could go ahead and offer up any feedback on implementation that you have concerns about, areas of deeper questioning. I know that many of you will want to read the summary. I think that it will be extremely important for us to get from you all areas that you feel lack clarification, that you have the greatest concerns about implementation, anything that is just you're seeking higher clarification on, because I think that since, as Bob mentioned at the top of the call, as we are waiting on those interpretive guidelines from CMS, I think that would be an area where we can help to push CMS with our questions or concerns to help make sure they illustrate or define those areas for us in those guidelines. So at this point, I'm going to ask Heather to take the call off of mute. So if anyone has any questions, I would welcome those at this time.
Joy, this is Joanne Cunningham. Hello.
Hi, how are you doing, Joanne?
Good, how are you? I am wondering, from the association standpoint, we're talking internally about asking our delegation to advocate for a delay in the implementation. These are arguing that these are pretty significant changes, and a July 13th start date is, in a lot of ways, very unreasonable to expect home health agencies to be able to, be up to speed on, executing these. Is there any discussion from within VNAA about doing similarly, asking for a delay in the implementation?
So to be honest, I think that's part of why we're talking to you all additionally on the implementation of feedback. I will say that they were pretty clear that they thought that this is something that could be achieved within 6 months. Obviously, I do feel like there is a lot of work that will need to be done. I think it's important we get feedback from members on specific areas. So I don't know if they'd be willing to push the full effective date, but we might be able to get a modification on a specific area. I do think that there is a lot of concern about delaying it in any way, and I don't want to put all my eggs in the basket of being able to delay that. I want to focus on what might need to be done in advance. But no, I think it's something if the membership feels that there are definitely areas that they don't feel like they could get up to speed, or especially if we're going to be waiting on the interpretive guidelines for quite some time, we'd be happy to work together on that.
There's something that came across to it, because the interpretive guidelines obviously are going to be very delayed. Occasionally in the past we've gotten dispensation on enforcement, even if they didn't want to change the word implementation. Right. So although they could technically say at 6 months you've got to have it implemented, if we can say that it's going to take another 6 months or another year before they actually enforce it, or 6 months after they put out the interpretive guidelines, because it's the interpretive guidelines that guides enforcement.
And I think that's going to be part of our ongoing conversations with them around this, because as we've mentioned, these are pretty significant.
Hello.
Hi.
Hello, this is Joy, Chilton in Vermont, and one of the things that I was thinking about is the emergency management standards. I thought that there was already a deadline for us that was later in the fall, and does this, having them included in these COPs, move the deadline back for us then?
And that is something I've already asked CMS about, asking them for clarification of that once it proceeds, as they both say home health agencies. My concern is that it's going to be the earlier date, but as soon as I do, I'm writing your name down, as soon as I do get confirmation from CMS on that, I'll be sure to circle us all in.
Okay, thank you. That's certainly something that seems discrepant, because they've already given us a different deadline.
Yep. Okay. Are there any other questions?
Hello?
Hi.
Hi, this is Linda from Michigan. And it seems to me that when we heard about the revisions that were coming to the COPs, that there was some discussion about the professional advisory committee going away and the requirement for annual evaluation and policy review. And it doesn't look like that's incorporated into these revised conditions. Is that in fact gone?
I didn't see it either, and they talked about eliminating it, so I didn't see a separate reference saying it's been deleted, but I sure don't see it, and they talked about eliminating it.
Yeah, I agree. I didn't see the elimination of that either.
No, it's in the crosswalk.
Oh.
Joy, another question. You referenced a summary. Is that on the website, or?
That is all going up on the website on Monday. We'll be posting the recording of this webinar. We'll be posting the summary. Here, I'll advance 2 slides to show you guys. So, as I have the controls. there. So what we're putting up on our website on Monday will be the webinar itself that's being recorded right now, the PowerPoint, a link to the CMS regulations with comments, a link to the Federal Register version of the comments, an overall description of the changes, a separate list of changes from proposed to final, and then a side-by-side of the previous regulations and the new regulations so that you'll have their changes occurred. So we are hoping to have all of that up and posted Monday. It will also be highlighted in our membership update publication that we send out weekly that will provide you a link to where on the website it's all stored in the policy section. So all of that will be in one area together for you to help you begin to navigate this work.
I have a question.
Okay.
In the conditions of participation on page 4582 in the center column, it identifies clinical disciplines that can certify for eligibility, and I noticed that occupational therapy is listed in there. Are you able to clarify that?
Okay, I will say in front of me I have the commentary version, not the actual, not 4582 in front of me, so it's a different. Can you give me a subsection, or can I get you an email and email you back?
Yeah, sorry, I don't have it in front of me. I just have notes from an earlier education I received this morning.
Okay. Can I get your email then? Would that be okay?
Sure. It's S as in Stephen, I as in Indigo, D as in David, D-I-O-R at C as in Cat, H, S as in Stephen, dash, M as in Michigan, I.com.
All right. I will, when I look at the regs side by side of 4582 and I can see it exactly, I'll circle back with you. Unfortunately, I've got the longer CMS commented version in front of me.
It's 4580, page 4582 of the Federal Register printed out version, middle column.
Yes.
And that's where they're talking about standards for the revision of plan of care?
I think so. Again, I don't have it right in front of me. I didn't bring it. But yeah,
the issue was the omission of OT in which part?
Yeah. Oh, it adds OT.
Yeah.
As being able to certify for eligibility. So is the implication that OT can open a case?
Ooh. Well, this is Joy Chilton. I looked at that too, and the way I read it was that the COPs apply to everybody in the Medicare certified, and it doesn't matter who's paying for it, but the Medicare billing is what limits you to not have the OT do the admission.
Okay.
Yeah, that sounds more plausible.
Right.
It's certainly worth looking into.
Yeah.
Could you repeat that? I'm sorry, I don't think I understood.
The way I read that was that as part of the COPs apply to everybody that you take care of in your Medicare certified home health. So that may include other insurers. And so other insurers may not have an objection to an OT opening a case. So these are separate from the Medicare, billing rules. So it'll be good to get a clarification on that.
Yeah, I'll add that to what we're going to clarify. And several of you have the question. I'll make sure it's publicly available to you all.
Joy, this is Andrew Koski at the Home Care Association.
Hi, how are you doing?
Good. Another discrepancy that I want some clarification on, and I tried to get to CMS, but I haven't gotten a response, is that in section 484.60, they talk about every patient must get a written plan of care, but then if you look at 484.50, in the comments section, they said they removed the requirement that every patient must get a written plan of care.
Right.
So that to me was a discrepancy, and I was wondering whether you had looked into that, or if you could, any understanding on that.
I thought it was written by the second visit. Could be. I'm not sure what that is.
We need to have everyone mute their phone so it'll stop.
Yeah, let's never do that again. I thought that it was the written comment within 4 business days after the first initial evaluation. But I see what you're saying here, that in 60, okay. I'll ask for clarification on that as well. I think these are all problems that we need to clear before we can implement fully.
Thank you.
Hello.
Hi, how are you?
If we could do the chats, please.
Could we? I'm sorry.
Are there any chats that have been written? I believe there's some written questions under the chat.
I've been most of them have been asked. I'm scrolling through now.
Okay. We had asked one.
Sure. Let me.
This is Jan from Aspirus at VNAA in Wisconsin, and we were just wondering if you could clarify for us the need for home health aide certification when a state doesn't require that certification.
I was just about to say it looked like I had one question that wasn't answered, and that was the home health aide certification when not required by the state. It looks like their language offers you what they want to have be the training necessary. But I do see where we would want to see if state law does in fact supersede. My thought though is that because this is Medicare, not Medicaid, that they would be able to put in place a certain level of training that they require that would be able to cause the training to be necessitated. However, I am happy to put forward that question as an area that we need clarification on as well, based on, you know, if what comes first, the state law or CMS. I'm happy to do that and circle back with you guys.
Sounds great. Thank you.
Okay. Let me see if we have. I apologize. Some more chats came in. That was our occupational therapy. Go ahead. This one was about, one of them was about emergency preparedness and what comes first, that reg or the COPs, and that we've talked about. About, you know, getting clarification of that. Another one has the question around tabletop exercise versus a full-scale exercise. That is, again, that's going to be another thing where we need to see if the emergency preparedness regulation or the COP has precedence, especially since they both, that the emergency preparedness regulation refers specifically to home health, as well as obviously the home health conditions of participation refer to home health agencies, so we do need to get clarification at that point. All right, those are all my chat questions. Do any of you all have some other questions? Okay, if not, obviously we are just beginning the conversation. I know a lot of us are trying to figure out the best way to help folks implement it. I'm going to take these questions, and I would encourage you to carry the message back of any areas that you feel need more clarification or there's some confusion, to please bring them to me so that we can make our case to make sure that all of the guidance that is provided by CMS and get clarification on those, on who supersedes who, and then also specifically if there's a need to push, whether it is through they're not going to, whether we get a true implementation delay or whether they are just not going to enforce the regs until a new stated date. I think that all of this will be extremely vital to our advocacy on that effort and then also making sure that you are all prepared as much as possible. Again, this and the list of resources that you see in front of you will be posted to the VNAA website on Monday. And I will also, on the last slide, there is my contact information. So if any of you need to get back in touch with me with any of these questions, feel free to reach out at any time. I'm more than happy to answer questions or take forward those comments and concerns as well. Obviously, this is the first of probably many conversations that we have around the conditions of participation. Thank you all so much for calling in today. I greatly appreciate it. Yes, sir.
Hi. I just wondered if I could ask one question before you close.
Sure.
Hi. Thanks. This is Al Cardillo in New York. And certainly while one can point to the merit of many of the strength and standards, if you will, that are lined throughout the new COPs, one of the real dilemmas is that they really fly very counter to home care's role and desired role in many of the integrated models of care, whether it's in managed care or in connection with ACOs or advanced primary care practices or independence at home programs. We can just go right down the list. Because clearly the COPs are heavily focused on still the concept that the home care agency kind of owns the patient, is the medical home for the patient, and has all those responsibilities. But in a world where increasingly home care can play a very vital role as a strategic partner in, say, in combination with a primary care practice or any of those other models, the agency might instead be performing a very specific and discrete task as part of a broader plan of care that the other entity, if you will, is organizing and overseeing. Given many of these COPs would take the agency into a position where it would then have to exercise or follow a whole set of rules that weigh down both cost and administratively and time-wise the agency's response in one of those strategic partnerships, thereby making it either less affordable or certainly less desirable from the standpoint of one of those partners. Is there any effort or in consideration that in reaching out to CMS with respect to interpretive guidance, whether there can be guidance that really aims at providing flexibility for home care in these alternate models?
I think that that's definitely something I do want to see if they're willing to do that. Unfortunately, I think so much of whether it's our yearly update around the PPS or its guidance like this, they are very much mired into the traditional fee-for-service modeling. They aren't looking at where the rest of CMS has stated they're going, which is 80% of care in some type of bundled or value-based relationship. I think that there's a bit of a disconnect between those two things, and I think that's definitely something that we're going to highlight with them because I do think a lot of these roles that we do play, I do think we do strategically play a great job as that care coordinator, and that's something I'd like to see elevated in some of the relationships with ACOs and other managed care organizations. But I do think that there needs to be a level of flexibility that if you're working with any level of integrated system or caring for individuals, like you mentioned in Independence at Home or PACE or any of these other programs, that we need to think about who owns which portion of the person and what aspect. I do think there are parts of the COP that talks about making sure all the physicians are included and service providers are included in that dialogue. I think that touches on that a little bit, but a lot of the traditional aspects of reporting and plans of care tend to defer back to the more traditional and historic role of home health in that fee-for-service model. So I do think that there needs to be some clarification, probably a little edification, and thinking outside the box about how to make home health be able to continue to work at all those different levels of where healthcare is going. you know, healthcare has evolved a great deal since the COPs were last updated. It has, I would even say, arguably has moved, you know, tremendously in the past 2 years when these were last proposed. So I do think that there is a lot that can be gained from that aspect of the conditions of participation in the interpretive guidelines.
Thanks very much. Thank you.
With that, if there are no other questions, I do again want to thank you all for joining us. I also want to thank Bob Wardwell for calling in once again and helping us step through these conditions of participation and the changes that are ongoing. I appreciate his insights, and I also appreciate him reaching out already to CMS to start talking about when and how soon and we can see some of those interpretive guidelines. I look forward to working with all of you, and we'll circle back soon. Again, on Monday, we'll have posted these resources that will be available for you, and that we stand ready to take your questions and forward them through to CMS to try and make sure we get as rich and meaningful guidelines, as well as when those implementation dates will truly stand. So thank you so much, and I appreciate your help.